Leaders, colleagues, ladies and gentlemen, good afternoon. It's really great to be back with IPDI, one forum that I have been really fascinated with, and I take this opportunity to congratulate my friend, Professor Dr. Mohsin Ahmed, for his tremendous endeavor. IPDI is a big name now, so it's always a great feeling to be together with IPDI. So today I've been asked to talk on below-knee interventions, challenges and prospects. I'll be giving you the Bangladesh perspective. This is where I work in ICBD, you all know. We have got a vascular department now which has been expanded. I always say this to you because this is a big news for me. And the BSH on the right hand, you can see we have a good vascular setup there as well. So that's also something that I can mention. So, as you know that the peripheral arterial disease, we call it PAD nowadays, not PVD anymore, and a huge burden of patients worldwide, in Bangladesh as well. And endovascular interventions are really something that benefit a great majority of these patients. When you talk about the below-knee diseases or the infrapopliteal disease, we have this Basel trial who came out recently, Basel 2, because we have been waiting for this result of Basel 2 trial. It took a long time for these results to be published. It's now in Lancet 2023. You can see that just recently published. They say that intervention is superior to surgery in below-knee disease. So this is something that is real news for us, especially for this topic. So some anatomic variations that takes place in the popliteal trifurcation, very important to know for the interventionist and stick to, because the actions really need to be customized based on this sort of anatomic variations. As you can see, tremendous variations, and the type of circulation that the pedal arches and the foot circulation that we experience has tremendous variability. We know that the anteriotibial artery, posterior artery, as the peroneal is there, but there is tremendous variability in the contribution of these arteries into the foot circulation. So this really need to be taken into consideration before we plan an intervention. Angiosome concept is another thing. Which part of the foot being supplied by which particular vessel, and to be able to revascularize that particular vessel means a lot in wound healing and relieving symptoms of the patient. So this is also something that needs to be considered. But I know that there are authorities who say that this is not that particularly important. I'll be showing you. This is one particular study that came out that tends to claim that the angiosome concept had no impact on their clinical success. Okay, I think this is one isolated series, but most of the authorities here or worldwide, they tend to say that angiosome does matter. So what is the current practices? POBA is the thing that we used to do over a long period of time now. We have had the drug-coated balloons, we have the bare metal stents, mostly coronary stents being used in the infrapopliteal vessels, and the drug-eluting stents, the coronary stents. DCB, much better than POBA, that has been documented in studies. Here is one study like that. Coronary stents, well, gives immediate results, of course, but it hampers with the future reintervention that might be necessary. So our cases, we did quite a lot of cases, but we haven't really been able to remain consistent on our practices here. So POBA is the thing that we have been doing. So good results. I mean, this is something that I did, say, 7-8 years back, so nothing to be rambling about this. So this is pretty simple. You take the wire across the lesion, you inflate the balloon, and you come out, and the result is sometimes as good as this. You can see, you can be very happy about it, but see, there will be very, very complicated situations, you know. So you have to be really familiar with what really needs to be done in complicated situations. This is DCB experience for TPT, you know, very diffuse disease in the TPT, tibial peroneal trunk and the tibials. What we did, just we took one DCB and inflated, and the results not really bad. So this is what we became happy about when he came out. And this is one recent case who had his SF lesion together with BTK. So we did the tibial first, then we went for a kissing for the tibial peroneal trunk, as you can see here. We do the kissing stent technique all the time for the autoiliac, but it is possible to do the kissing for the below-knee lesions like this as well with good results. Some of the hardware that were used in this particular case, command years that recently were made available to us and pretty good in dealing with the balloon lesions. And PTC where sometimes comes in very handy. Plain balloons, of course, we have those at our hands all the time, coronary balloons. So those are the things we used in this particular case. Some of the basic things, I mean, the approach always the retrograde femoral, that is the most common approach. We have the retrograde, antegrade femoral as well. And the tibiopedal, we have very limited experience with the tibiopedal retrograde. This is some of the things that we did this. I mean, we are familiar with the antegrade approach. We did some a bit, I mean, tedious, and we have to really keep your focus on the femoral head. If you miss it, then might end up with some sort of complications. Retrograde pedal, like I said, it's not something that we are very familiar with, but possible. We can do it. Tips, well, a lot of them actually, if we go point by point, there will be a lot of things that I can tell you, or our experts are here, they can tell you. But some of the things, these vessels are diseased and very prone to spasms and dissections, even perforations. So we really need to be very gentle in handling these sort of cases and be able to handle the spasm thing very well, keep in hand the antispasmodic drugs and all those things so that you can come out with some sort of results here. And don't attempt 100% all the time, because the studies say that even if there is residual stenosis of 30%, be happy with that. Don't attempt 100%. There are a lot of things here. I can take a look at this. So these are the issues, like I said. So you have to be very alert in avoiding these sort of situations. So what is the present situation here? I mean, there is no study like we can always say. We don't really keep our data, so we don't really know. But this basic question, has this technique really taken off in Bangladesh? Yeah, it has taken off, because we do it. We do it at NICVD, we do it at BSH, there are some other centers, of course, we do it. But to be meaningfully doing it and doing it consistently with good results is altogether a different thing. So why not? If not, then why? I mean, there are some issues I can mention, like the hardware intensivity, because we have a whole range of things that are necessary. So we don't have all those things all the time. That's one thing. And we have to have some dedicated personnel who will take up BTK as their passion. And the photograph you can see here is Marco Mangi. Marco Mangi is somebody from Italy. I met him and I saw him perform live on some conferences. He goes all over the world and performs tibials with all those hardwares and fancy techniques, the tibiopedal loopings and all those things. So he is a big name in, he's an IVR guy, he's not a vascular surgeon, he's an IVR guy. It's an IVR guy making a name like that all over the world with his tibial technologies and the expertise. It's an example for all of us. So I will urge our next generation vascular surgeons to be encouraged, to be inspired by somebody like Marco Mangi and take up tibials.
Thank you, Bashar. I think an excellent presentation. I think